Can you hear me?
Yes.
Yeah? Okay, great. So thank you very much for the invitation. When you said he's modest and he's from Scotland, I thought you were going to follow up with he has much to be modest about. I am from Scotland, where I run a bronchiectasis clinic with about 1,000 people from all across Scotland who have different kinds of bronchiectasis, including a lot of patients with primary ciliary dyskinesia. And I've had an interest in this condition for about 15 years. And just in the last couple of years, we've set up a research centre in Scotland that looks at different aspects of bronchiectasis, including looking at cilia. I was given complete carte blanche to talk about whatever I wanted in bronchiectasis research, so you could kind of call this talk stuff I wanted to talk about and I think is interesting. I hope you'll find it interesting as well. When my wife saw the programme, she sort of misread it and thought I was doing the Build-A-Bear workshop. She said, "You'll be brilliant at that!" And she was very disappointed that I was giving this talk instead. So I'm going to talk about three things, really, based on a little bit on what I was asked to talk about. One is around killing bugs, which we know is really important in bronchiectasis, different ways of killing bacteria and preventing exacerbation, so I'll give you the latest on that. A little bit about how inflammation happens in the lung and what kind of treatments are being developed to try and deal with inflammation in the lung. And then the last part, I'll talk about more blue sky thinking around how bronchiectasis might be cured. I've put it in inverted commas, so you know I'm not going to finish this talk by telling you that we have found the cure for bronchiectasis. But hopefully I'll give you some ideas. So we're all on the same page. This is what happens in bronchiectasis. It's widening, dilation of the airways. So the normal lung is like an inverted tree, and you can see those nice narrow airways going down to the bottom of the lung where gas exchange takes place. In bronchiectasis, to varying degrees, you get damage to the walls of the lung. That causes a weakness that allows dilation, widening of the airways, and that leads to recurrent infections. So the main features of bronchiectasis are that dilation. The lungs become obstructed with mucus, and mucus is a great medium for growing bugs, and so that's what leads to infection. That damaged lung leads to less oxygen getting across into the bloodstream, which means that patients feel more tired or more breathless. And the areas of lung can eventually become essentially non-functional, like little cysts. In most cases, we can stop this progression of disease from happening with good treatment, and I'm going to show you that we're getting much better at treating bronchiectasis. Another way of thinking about the different treatments and also the different areas of research in bronchiectasis is this idea of the vicious cycle. So you have essentially four components to what we talk about the condition bronchiectasis. You have infection, inflammation, and the infection causes the inflammation. That's your body's attempt to fight the infection. You have the impaired mucociliary clearance, which is obviously where people with PCD enter this cycle. And then the damage to the lung that happens as a result of the inflammation and the infection. And this cycle goes round and round and self-perpetuates. So each one leads to the other, resulting in progression of disease. So the objective is really to break the cycle by introducing therapies at different levels that you can then stop those different aspects from happening. Can't come to a cilia meeting and not show pictures of cilia. People with primary ciliary dyskinesia obviously have problems with cilia. What you may not realise is that bronchiectasis as a whole is essentially a ciliopathy or a cilia problem. So people who don't have a known genetic problem causing slow cilia will have slow cilia if you go in and do a biopsy and look under the microscope at what's going on with their cilia. But we call that secondary ciliary dyskinesia because there's something else that's causing it apart from a gene. Although the more we learn about the genes, and you heard about that this morning, the more those patients are being found to have genetic problems as well. And so even patients that don't have PCD-associated bronchiectasis, and PCD is probably only about 10% of all bronchiectasis, have this problem of not being able to eject the bacteria from the lungs. So what kind of treatments do we have for bronchiectasis? We have systemic and inhaled antibiotics. I'm going to talk a bit about research into that, which tries to target the infection part of it. We have anti-inflammatory drugs, of which macrolide antibiotics are probably the main one that we use in practice, but some people get steroid inhalers, as I'm sure you know. Airway clearance, which is absolutely critical, and everybody should get that. And we don't have an awful lot yet to target the structural lung disease, apart from the very rare cases where we use surgery. I'm not going to talk a lot about surgery because I think we've gotten so good at treating the bronchiectasis, we almost never have to send people to surgery anymore. But it was the dominant treatment for bronchiectasis until about 30 years ago, and still in parts of the world like Eastern Europe and Asia, a large proportion of patients still get surgery for bronchiectasis. So the areas where we're targeting treatment, and therefore where the research is going on, are trying to treat the underlying conditions, improving mucociliary clearance, and that's physiotherapy and mucoactive medicines, preventing infection, treating airflow obstruction with things like bronchodilator inhalers, and trying to then prevent exacerbations from happening. So I'll start by talking a bit about infection, and particularly about the more recent research into infection. In people with bronchiectasis, which includes PCD, about 2/3 of people will grow bugs from their phlegm even when they're well. A lot of patients think that if you grow a bug, it means there's an infection there that needs antibiotics. That's not always the case. So some people will always have bugs that live in the lungs, and you don't necessarily need an antibiotic if you're feeling well. The most common bugs are the ones that you see on the slide: Haemophilus, Pseudomonas, Moraxella. These are bugs that you'll get in your sputum cultures on a regular basis if you've got a condition like bronchiectasis. And our research suggests that more severe patients get bugs like Pseudomonas aeruginosa. So it's a bug that has a higher risk in terms of outcome, in terms of being admitted to hospital, but it's the less common bug. So in people who have earlier stage disease in the UK, 50–60% will have Haemophilus. And Haemophilus is not associated with much of an increased risk of being admitted to hospital or having chest infections. And that's because it's actually something that lives at the back of your throat if you're a normal person. So while it causes a bit of inflammation, it's not as associated with poor outcome as things like Pseudomonas. But we need better treatments to treat those people that have gram-negative bugs and Pseudomonas, because we want to stop people having chest infections. So to do that, we need to develop new ways of giving antibiotics. And the way that we do that is to do clinical trials, and I do a lot of clinical trials. So why do we need clinical trials? Why can't you just take an antibiotic because I say you should take an antibiotic? I'm going to get interactive now. Come on. Surely, if I've got an antibiotic that works against Pseudomonas, and I give it to you because I'm a doctor and I know what I'm doing, why shouldn't that just be the treatment for bronchiectasis? Why do we need clinical trials?
Because it's got to be specific.
Yeah. So, yeah, okay.
For that person.
So it has to work for that person.
Yeah.
You need to prove that it works. Yeah.
No side effects.
And you need to prove that it's safe. Yeah. So we've had treatments for bronchiectasis for hundreds of years. But until recently, we haven't had any trials to show what works best for individual people and what the sort of safety profile is. So you need, for any treatment that you're being offered, to know, does it work? Is it likely to work for me? And what's the safety profile? Because actually, doctors don't have the greatest record of providing people with the best advice of what to do. And there's some really nice examples here. I particularly like asthma cigarettes. So you can't always just go, well, antibiotics, that sounds like a good idea. Don't need any more evidence. I'm just going to take those. So we need clinical trials. And so the wonderful thing is we're now in an age when there are dozens of clinical trials in bronchiectasis going on all the time. And so we're getting more and more information about what works, and particularly what works for individual people. So I love clinical trials. Does anyone know when the first clinical trial took place? Have a guess.
Is it cowpox?
Sorry?
Cowpox.
It wasn't cowpox, but that was a while ago.
Yeah.
So the first recorded evidence of a clinical trial.
Was it penicillin?
It wasn't penicillin. So penicillin was 1940s, 1950s, so it was before that. There's two things that claim to be the world's first clinical trial. I throw this in just because it's really interesting. The first is in the Bible, where there's a passage in the Bible where a king is complaining that their servants all look kind of tired and lethargic. And the suggestion is that to stop letting them drink wine and the sort of rich desserts that we had for lunch, and to give them just water and vegetables to eat for a week. And so the king does the randomized clinical trial of giving his servants vegetables and water, and lo and behold, they're energetic and happy again. The world's first clinical trial. But the one that is the world's first controlled clinical trial was actually in 1747, which was a guy called James Lind. So we have a thing in the UK called the James Lind Alliance that sets research priorities for NIHR, which is the big funding body in the UK. And the reason it's named the James Lind Alliance is because this is the world's first randomized clinical trial. And this was 12 sailors with scurvy. Scurvy is vitamin C deficiency, because people who went on sailing ships for long periods of time didn't get any vegetables or any fruit, so they didn't get vitamin C, so they got scurvy. And he tried 6 different treatments: cider, vitriol, which I have no idea what that is, vinegar, seawater, orange and lemon, or spicy paste. And everybody got scurvy apart from the ones who got the oranges and lemons. Isn't that great? That's a controlled clinical trial, the first ever reported in the world. So you need to do this to prove that things are safe and to prove that things work. And so gradually we've been working through the things that we think work for bronchiectasis to do trials. And the first one I'm going to talk about in terms of trials is antibiotics. And one of the biggest problems with antibiotics is we all know antibiotics work. Because when you get a chest infection, you get a course of antibiotics and you feel better. But often patients will tell me, I get a course of antibiotics and I feel better for about 2 weeks and then I feel worse again. Or I need 3-4 courses of antibiotics before I feel better after a chest infection. So why does that happen? One of the possibilities is that not enough of the antibiotic gets into the lung. So again, I'm going to make you do some work in this presentation. So if amoxicillin is the one we use a lot, if I take 250 milligram tablet of amoxicillin, have you got any idea how much of that ends up in my lung, in a sputum sample where the bugs are? Any idea?
C, 0.1%?
C, 0.1%? Any advance on that?
No, C, I think.
We'll play Brucey's Play Your Cards Right. Higher or lower? You can tell the people who are my age in the audience who got that. You're right, actually. It's about 1 in 1,000, 0.1%. So Peter Cole did this stuff at the Brompton about 40 years ago. It's about 0.2 micrograms, which is enough to kill most bugs, but it's a tiny, tiny amount of what you actually give. Most of it goes everywhere else, and so you get side effects. So how do we get past that? Some people will be very well familiar with things like macrolide antibiotics, and I'll show you in a minute different ways of getting more drugs to where it's supposed to be. Because the problem here is potential side effects, and also waste, so we're wasting all of that stuff. I refer now to a famous philosopher. Who do you think is the greatest philosopher of all time? Aristotle? I have a better one than Aristotle, which is Forrest Gump, who I think is the ultimate philosopher. What's Forrest Gump famous for saying? Life is like a box of chocolates, yeah. So treating bronchiectasis is like a box of chocolates. You heard it here. Because everybody's different, but also the problem with antibiotics is we have the typical way of giving antibiotics is like eating 1 chocolate and then throwing 1,000 of them away. It's a complete waste of money and resource, isn't it? So we need better ways of targeting antibiotics to where they're supposed to go. Anybody here been on prophylactic azithromycin? Lots of people. What? Yeah. So why is azithromycin so good? Anyone know?
Because it's a broad spectrum.
Anti-inflammatory.
So it has some anti-inflammatory effects, but the other amazing thing about it is that it gets concentrated inside your cells. So you know, I said amoxicillin, tiny amounts get into the phlegm. Your body has these inflammatory cells called neutrophils, which circulate around us like seeking missiles for infection. This drug gets concentrated inside them, so when they're running after an infection, they take the drug with them, so they get huge amounts of drug right next to where the infection is, and we think that's part of the reason why they're more effective as a prophylactic thing than taking just a low dose of amoxicillin, for example. So
What's the trade name for that?
So Zithromax is the trade name for that one, yeah. But there's others of those. Clarithromycin is a similar drug, for example. So I'll show you some results of trials. This is randomized controlled trial of patients with bronchiectasis randomized to either take macrolide antibiotic or placebo. The numbers are here, so 173 patients getting a macrolide, 168 getting a placebo, a fake pill, so it's James Lind would be proud, it's a controlled clinical trial. And this is the number of people having chest infections. And so people, over a course of a year, some people have chest infections, some people don't, and the percentage reduction is 50%. So 50% less people have chest infections if they take the prophylactic antibiotic than if they took the placebo pill. So that's great. We've been using this for a long time, but until the last 5 or 10 years, we haven't had any evidence that it's effective and safe. We now do in a large enough group of patients, and the side effect profile was about 10% of people got gut problems. No people got hearing problems in these particular trials. So it appeared to be safe, and it appears to be effective. So this is now recommended by the guidelines for anyone who's having frequent infections. So it shows you the benefit of randomized clinical trials. It tells you who's most likely to benefit and what the benefit and safety profile is. So I can now say to my patients, if you take this medicine, it'll cut your exacerbation frequency by half on average, which is what the trial showed. Okay. The other way of putting antibiotics at higher concentrations into the lungs is to allow people to inhale them. And some people in this room will have had inhaled antibiotics as well, through a nebulizer or through a dry powder. And the idea is to put a lot higher concentrations of antibiotics into the lung. This has been slightly more difficult to demonstrate benefit of in people with bronchiectasis, and I'll take you through just in the next 5 minutes why. We recently finished the largest study of this ever in bronchiectasis. This was 2 big studies, cost about $100 million to do the 2 international randomized trials, giving 28 days of antibiotic treatment, giving people 28 days off and then going on again for a whole year. Over 600 people around the world took part in this trial, and the idea was to see, does giving antibiotics through an inhaler reduce exacerbations? This was incredibly good at getting rid of bugs. So people had bugs in their phlegm, got them to cough up samples, plated it out and counted how many bugs were in the lungs. And every time they took the antibiotic, the number of bugs went down dramatically. So it works good at getting rid of bugs. The placebo is in the yellow here, so you can see it doesn't change very much. We did 2 studies, because you have to do 2 studies to get a drug licensed in the US and Europe. One of the studies, there was a clear difference in the frequency of exacerbations between the 2 groups. In the other study, there was no difference at all. Isn't that frustrating? So it does seem to work, but not for everybody, which is, I think, kind of what we know from people's experience when they talk to me. Some people say, that drug you gave me was brilliant. Some people say, that drug you gave me did nothing. It's very hard to predict who's the one who's going to benefit. So we need to understand why studies like this don't work, and what could we do differently. Which leads me into a discussion of designing studies badly. Because we don't know a lot about bronchiectasis and rare lung disease in general, we often don't design studies in a way that's well adapted for the patients that are doing it. I'll give you a great example of bad study design. Does using a parachute prevent death or major injury when jumping out of a plane? What do you think? Yes or no? Only if it's open. You should be designing randomized clinical trials. So this is a real randomized clinical trial. Okay? So randomized controlled trial, the outcome is death or major injury after jumping out of a plane. This was published last year. So they screened 92 people, asking them, do you want to take part in this trial? Anyone want to do this trial? No? Only 64 said no, so there are some crazy people in rural England. 5 deemed unsuitable, so they must have liked them. But 23 people got randomized. 12 got the parachute, 11 didn't get the parachute. And at the end of the 9 people completed the jump in one group and 11 completed in the other. And nobody died and nobody got injured. Conclusion, jumping out of a plane is completely safe without a parachute. What's wrong with this study design?
Planes on the ground.
Exactly!
This one.
The plane's on the ground. It's a lovely kind of thought experiment of bad trial design. If we go back to my study, half the people never had a chest infection. The outcome's a chest infection, but half the people never had a chest infection. They were giving antibiotics to people who were very mild with bronchiectasis, who were never going to have the event that they were trying to measure. The plane was on the ground. If you treat the wrong people, don't be surprised if you don't get the right answers. So we need to be more careful about how we design studies. When we reanalyze these studies with inhaled antibiotics and focused on people that have very high levels of bugs in the lungs, suddenly the improvement in quality of life is a 10-point improvement in a questionnaire, which is the Bronchiectasis Health Questionnaire, which is transformational. Patients feel amazing if they get these drugs, if they're the right sort of patient. So we need to move more towards personalised medicine, which is this idea that I'm sure you've heard other people talk about before, which is not this drug is for bronchiectasis or this drug is for PCD. It's this drug is for this person. This drug is the right one for this individual and their type of disease. Other developments in infection. Most of you, if you've got PCD, will be putting sputum samples into the lab. Do you know what happens with sputum samples when you send them to the lab?
Sit around for hours.
They sit around for hours, that's right. Or they get lost. Yeah, so they
I might get a phone call a day or two later saying you need to start your antibiotics or a different one.
Yeah, so this is a point of enormous frustration for everybody, because what happens, they go into the lab, if they get there at all, then somebody processes them, puts some stuff in, plates it on a plate, and this is a very unscientific method, so they just take the sputum and smear it on a plate, put it in an incubator for a couple of days, and come back and look and see if something's grown. And if something's grown, they go, that's an infection. And if something hasn't grown, it's not an infection. The thing could have died in the taxi on the way to the hospital, the sample could have been contaminated with all sorts of things, so there are big limitations to culture. By the way, I'm not saying don't do culture, it's important, it's the best thing we have at the moment, but it's not perfect. So there are technological advances that are probably going to make in the next 5 years culture not part of routine clinical practice. This is one example. This is a little device called a MinION. If you put it into Google, it's spelt the same as Minion, so you get little yellow cartoon characters. And what it is, it's nanopore technology, which is these tiny little pores that take DNA through the system, and it sequences DNA right there and then attached to your computer. And so you can put DNA extracted from a sputum sample into this thing, and using this amazing technology called WIMP, which is what's in my pot, it does all of the analysis of the DNA for you and spits out the other side that this sputum sample contains Haemophilus or Pseudomonas or whatever it happens to be. So within 6 hours you can get the answer of what's in the sputum sample, and because it's DNA, it doesn't matter how long the sample was sat there for. It gives you what DNA is in the sample. So there's a first study with this just recently been published with 40 samples, and it was more sensitive, so it picked up more infections than the culture method and was considerably faster. So the future is very exciting in terms of how diagnostics are developing. What about inflammation? This is an area that's kind of my interest, is we haven't really had good medicines to stop inflammation. We give lots of antibiotics, but steroid inhalers only work for a certain proportion of people. They don't work for everybody. And we don't have other good inflammatory drugs. The main cells that cause inflammation in bronchiectasis are these little cells here. They're called neutrophils. They squeeze through the airways from the bloodstream, sit in your chest, and try and fight bacteria, and eventually will die in the airways. And they release enzymes that damage the lung. And so you don't want too many of these. Like any kind of response, you don't want too little or too much of inflammation. So they're very important, but until recently we haven't had a drug that really targets those. This is my favourite question. Why is sputum green? Does anyone know?
Infection.
Infection. True. Why does infection make your sputum go green? Why not blue or red or...
I'm not sure. Mine is always dark green anyway.
Yeah. Does anyone know? Has anyone ever told you why?
Is it bacteria?
It's not the bacteria. So lots of people think it's the bacteria, it's the Pseudomonas making something green, because in our heads cartoons of bugs are green, but bugs actually aren't green. Well, most bugs are not green. It's your body. Your body has one green protein in the whole body. It's a protein called myeloperoxidase, and it's in your neutrophils, which are your inflammatory cells. So when they home like a missile to wherever infection is, and if there's enough of them, then there's this green protein, and so things turn green. So when things are green, it means there's inflammation. Yeah? Isn't that cool?
Yeah.
Your body has a natural infection detection system, and it's green. It's like it's got a warning light, and it decided to make it green.
Mine is working very well.
So you're talking. So that helps us, though. So we have a really simple test that can tell you if you've got inflammation in your lungs. If your phlegm looks like this, you haven't got much inflammation. If your phlegm looks like this, you've got lots of inflammation. And actually, this works really well as a way of predicting who's going to have chest infections, when a chest infection is going to happen. So I think that's my favourite biological fact. Phlegm is good. Phlegm is helpful. But we need to develop ways of dealing with people that have phlegm that look like this, to make it not green, that are not just giving more antibiotics. And so this is when we get into what those cells do. And I've got a little video of what these cells do, because I'm very interested in these cells. So these cells are meant to kill bacteria. And I'll show you, they come into the lungs, like a missile, as I mentioned, to kill bacteria. And this is a little video of one of them. And this thing on the end here is a little particle of a bacteria. And you can see it's trying desperately to eat it. I want to eat it. I'm hungry. It's like me in the queue earlier for the sandwiches. Let me have it, I want it. Look at that, isn't that cool? So it knows where it is and it homes after it, trying to find it. We're teasing it now. Can't get it, can't get it. And then eventually we have to let it eat, otherwise it would get very grumpy. That's what's happening in your lungs, or in most lungs, all the time. And it's a really effective way of getting rid of bacteria. So that green thing, when you've got a cough or a cold and your sputum goes green, it's actually your body trying to get rid of the bugs by eating them. What we now know in bronchiectasis is that that's not what happens in people who have more advanced bronchiectasis. The body stops being able to eat bugs properly. So you can go one of two ways. You can either eat, which is called phagocytosis, or in people with bronchiectasis, what seems to happen is this other way of killing, which is where they essentially explode on the bacteria, and that causes more damage. So people, when they develop bronchiectasis, switch from the good way of eating, which you just saw a video of, to the less good way. And I'll show you a video of how that works. So this is what am I trying to say? The blue ones are the cells, and the red stuff is DNA that comes out when they explode. And I'll play this video. Oh, this is what happens when they meet a bug. Yeah, there we go. And you can see the clock up at the top showing how it happens over, this is 2 hours, and suddenly they've met a bug, boom, they all explode. Lets you understand what happens when somebody with bronchiectasis gets a chest infection. So normally they should eat them nice and cleanly, the bugs go away, everything's back to normal. But if your cells are primed to do this, you encounter a bug, they do this, it causes damage. So when a person says to me, whenever I get a virus or a cold, it goes into my chest, what they're really telling me is their cells can't do the normal way of clearing them, and this is what happens. So what we're trying to do is to develop drugs that can stop that process from happening. This is just so you know it happens in people. This is a picture of a sputum sample from a person with bronchiectasis. These are the cells, and this is all of that stuff that's exploded out of the cells. This is what happens in a patient, and this is not my image, but this is an image from a science paper about this, which shows you the cell, and what that stuff is doing is trying to capture the bugs and stop them from spreading, but it doesn't kill them. So it gives you a bit of an understanding of what's going on and why people with bronchiectasis are not so good at clearing infections compared to other people, because their cells start trying to trap bugs rather than trying to kill them. So we're doing some trials to try and find ways of blocking that from happening and get neutrophils back to doing what they should already be doing. There's some evidence that the macrolide antibiotics we talked about earlier do that, so they restore normal killing. And we've just finished a trial of a drug that actually switches off the main signal that causes that exploding process in the bone marrow. So when the neutrophils are being made, we switch it off, so that when they get to the lung, the only thing they can do is the eating and they can't do the exploding. And we'll get the results of that in the next few weeks, actually, and I really hope it's worked. Everybody's different. Everybody has different kinds of inflammation. So how do we know which person should get a medicine targeted at infection? How should we know which person should get a medicine targeted at those neutrophil cells? Who should get a steroid inhaler? We need tests that can differentiate between the two. And you obviously saw this on your Facebook page. We've just finished a study of a test that can tell you whether you've got these neutrophils that are misbehaving, which is a pregnancy test strip that detects an enzyme that comes out of these cells. And you take a sputum sample, you mix it up, and you put it onto the pregnancy test strip. And again, I'll run the video. Oh, I'm not doing well with my videos today. There we go. And you'll see here, the band comes up on this one saying, you're positive, you've got the inflammation, you probably need an antibiotic. This one comes up negative, no evidence of that neutrophilic inflammation, you're lower risk of having a chest infection and lower risk of having infection in general. So there's really exciting developments in technologies that can tell us which patients will benefit from which drugs. And the next step is, again, to do clinical trials to say, does it work to choose the right drug for the right patient? It would be really lovely to be able to tell you we're going to cure bronchiectasis. Unfortunately, even medicines like CFTR modulators, which I'm sure you've heard of in cystic fibrosis, which correct the basic defect in CF, don't appear to cure bronchiectasis in people with CF. So although there's lots of excitement about regenerative medicine, which is things like stem cells, there have been no studies of things like that in bronchiectasis. I really hope that we see things like that. But in the short term, the most likely way that we're going to cure bronchiectasis is to stop it from happening in the first place. And if you think of most conditions, heart disease, cancer, the best way of preventing those things is to prevent them happening in the first place. And there is lots of evidence that if you diagnose people earlier and you treat people earlier, you prevent conditions like bronchiectasis from happening. We see more and more people that have mild bronchiectasis like this. You can see the airways are dilated here, but they're quite small compared to these very big dilated airways, and this is very late stage disease. We see much more bronchiectasis like this because we're diagnosing it much earlier. Only about 10% of UK patients now have this type of bronchiectasis. We've just finished a study in India where that number is 65%, because diagnosis is much later. So you can clearly prevent progression to more severe bronchiectasis by doing earlier diagnosis. But most patients experience a delay of 5 to 10 years with bronchiectasis before they get diagnosed. And therefore it's often more advanced than it needs to be at presentation. There are now multiple reports of people with that milder form of bronchiectasis, what we call cylindrical bronchiectasis, reversing to having no bronchiectasis on CT if they're given antibiotics and macrolide antibiotics very early on, as in at the point at which it's first detected, before it becomes very, very severe. So at this stage, we're nowhere near being able to cure or prevent bronchiectasis like this. But this is one example of a case. This is Anne Chang's case from Australia, where you can see here quite clear bronchiectasis, and then on the repeat scan, it's gone with antibiotic treatment and macrolide treatment. So if you diagnose this condition early enough, it looks like the textbook treatment that it's completely irreversible is not true. This is a very much a minority of cases. But it does tell us we need to be much more effective at diagnosing this condition at the point that it develops and preventing it with good airway clearance and good antibiotic treatment. There isn't going to be one magic bullet for bronchiectasis, but cystic fibrosis tells us that you don't need one magic bullet. So this is the history of cystic fibrosis, from patients all dying in childhood in the 1940s, 50s, 60s to now a life expectancy that's going to exceed 50 years. And it didn't happen because of one medicine or because of one change in clinics. It happened because of all of these different drugs and different developments in how we care for people. So for bronchiectasis, it's likely to be like that. Clinical trials and clinical research adding one more brick on top of the other, and we gradually see improvements in chest infections, quality of life, and hopefully prevention of bronchiectasis as well. I think that's probably as much as I want to say, because I want to take some questions. I put that up just because I like funny things. Is there anything you want to ask me? Is there anything I haven't covered in bronchiectasis research that I should have done? Don't jump out of planes. I didn't say that.
Is there any research into bronchiectasis being done in England?
Oh, loads. Yeah. No, so bronchiectasis research is being done all over the country. There's a national network and a European network for bronchiectasis research. So there's trials going on all across the country. But it is patchy in that I get emails all the time from patients saying, I'm at this place, there's nobody here who's interested in bronchiectasis.
And I'm the patient rep for the Bronchiectasis Network, aren't
You are. And very good at it you are too. I hope you're not giving that up.